Thank you so much. It's a pleasure being here, and I'm thrilled and honored being invited to this meeting today and talking about some bloody stuff to you. My name is Thorsten Haas, as you mentioned by then. So I'm not from Gainesville. I'm not even from the US. I'm a German. So I had made a little round trip first in Europe. So I was working there for a couple of years in Germany, then 10 years in Austria, and then 10 years in Switzerland in a pediatric hospital. So I'm a trained pediatric anesthesiologist as well. And then 2.5 years ago, I moved here to the US, to Gainesville straight. And really because of the fact that they were looking for a director of that patient blood management program, which I am. So I'm more than thrilled and happy just to share what we're about to do here at Chance in terms of patient blood management. So the fun stuff about it is that most patients and most physicians does not have really a good idea about what we are doing. So this is like a growing work field, and I think in the next half an hour, a bit more, I will share that with you and also telling you how this may affect you, because I think this is something very important for each and every patient. So as usual, I'm giving my conflicts. I have no conflicts in terms of this project I'm talking about today. So start with a very silly and easy question. So I do the same also for medical students, and I'm happy also, you don't have to answer it here right away, but why do we actually transfuse blood? I mean, we all know about that. We all hear about that. We see that in movies, and every time they're transfusing blood, everything is, oh, there's something really dramatic going on. But the question really is, why do we transfuse blood? And the answer is pretty easy. So we want to make sure that all the oxygen we're inhaling, and the oxygen needs to get from the lungs to the tissue, to the organs where it's needed. And this is done by bloodstream. So that means once the oxygen is in the lung, and then it goes into the red cells, and then towards the tissues, towards the organs to really provide the life needed oxygen to the cells. So oxygen transport actually works like this. So we have like the red cells you see on the left side. And within each of the red cell, we have a protein called hemoglobin. And the hemoglobin is the one like catching the oxygen and transporting it to where it's needed at the tissue level. And if we look a bit closer, I don't want to annoy you with too many facts, but if we look a bit closer to these red cells, to the hemoglobin inside, there is one special protein or one special part needed to transport the oxygen, and this is actually iron. Most people are not aware that we have iron in our bodies, that we do have iron in our body. And iron comes from several sources, like if we eat vegetables, if we eat red meat, if we eat nuts or whatsoever, there's all iron inside. And so usually if we have like a good diet, we're taking enough iron which is going to be absorbed in our guts. And then we have that, it's going to be stored in the liver and the spleen. And whenever we need that, it's going to be released and it can be transported to the red cells or wherever it's needed. So we have sufficient iron to make sure we can transport all the good oxygen. Why am I telling this all? Because there's one special pathophysiology which is called anemia. You may have heard about that. So some patients are anemic. And the definition of that is actually that we either have not enough red cells flowing through our body, or we don't have not enough hemoglobin stored in our red cells. So in any way, if we are anemic, so the problem is that we can't get enough oxygen in time to our body organs. And the symptoms are, we're feeling weak, we're feeling tired, we may have headaches, we have problems with concentrating or loss of appetite or whatsoever. I mean, there's a bunch of things. What is interesting, if you just talk to the patients and asking them, do you think you're anemic? Most patients don't know. They kind of accept it as, that's how my body works. I'm always a bit weak, or I'm always can hardly focus on something. People are accepting it as normal, even though it is not normal at all. So now my question to you is, what do you think? We have 5.5 billion people on this planet here. What do you think, how many people are anemic? It's 1,000, It's a 10,000, it's a million. It's 2.4 billion people on this planet are anemic. Oh my God, when I've heard this number the first time, I thought like, well, that can't be true. Is that really like this? But yes, and if you check, because of the fact that most people, they are not sick. They're not feeling like, oh, I should go to see my doctor because I'm so like whatsoever. It's like a minor feeling of unpleasantness, like this bit of like weakness or whatsoever. Again, people are accepting it. So we started this program, and I will tell a bit more about this program in the next couple of minutes. And so we checked it, how is the situation in our hospital? So here at Chance. So we started to screen our patients about anemia, and we found that about 40% of all our patients going into a surgery, into a procedure, are anemic. This is just recent data. So it is still like a huge number. And now comes the hard part. So first of all, which are the causes of anemia? And that's primarily iron deficiency. And that's why I've shown that to you before. Now you understand when iron is lacking, when we don't have enough iron in our stores, so in the liver, in the spleen, and then we will not have enough when the red cells are going to be rebuilt, because our red cells do not live forever. They live like 120 days, something like this, and the body is going to reproduce these red cells like day after day during our entire life. And for producing new red cells, it needs the iron to build the hemoglobin. And if we're running out of iron, we can't build the hemoglobin really enough of time. Of course, there are other sources, like if we have like blood loss, that means it could be an acute blood loss, it's an injury, a trauma, whatsoever, but there can be also, again, like silent forms of anemia, like GI bleeding, so just a bit of a blood that's going into our stool all the time, just like a bit more heavy menstrual bleeding. Again, most people accepting it and saying, yeah, that's in my family, we always bleed a bit more. Even that may have kind of a source that can be treated. But anyhow, those can be like causes of anemia. Pregnancy, a new life is growing in the body, and this new life needs oxygen, this new life needs like red cells and iron. And of course, there are other issues like chronic infectious diseases whatsoever, so I don't want to bother you too much with that. Okay, so now I want to just like become a bit more personal. So now let's just talk about you and myself and my parents, my grandma. What if I need surgery? And what if I need surgery and I'm anemic? So I may not be even aware of that I'm anemic. But let's just continue on that. Which implications does that actually have? So first of all patients who are going into a procedure who are anemic, they have an average 20% longer stay at the hospital because they're a bit sicker. There are a zillion of things in the body that's going on during procedure, which prolongs my surgical stay. Now you will say, 22% longer stay, okay, that's not that bad. There's an almost 2 times higher risk of infection. So we're talking about pneumonia, we're talking about like kidney infection, like whatsoever. So just because, or just being anemic and going into a procedure, that affects the outcome. We need more blood transfusions during that procedure because if we are anemic and the hemoglobin is really low during the procedure, and the anesthesiologist or the surgeons are going to measure that, and at a certain point when it becomes critically low, they're saying, oh, this patient needs a blood transfusion because now it's a risky situation. We don't have sufficient oxygen going to the tissues. And it's a surgery, so let's transfuse this patient. There's, in addition, a higher risk of kidney damage. That is like the kidneys need oxygen. They need, especially like this high turnover of blood cells going through the organ. And especially during a procedure, when a patient is anemic before, that may become critically low. And we see that those patients with anemia have a higher risk of kidney failure. And that all leads to a higher mortality. So that means chances you will not survive that procedure are higher when you're anemic. So now let's think about that. So we're constructing a story. You're even yourself or your relatives going to see a doctor because you need a hip surgery. No trauma, no acute fall whatsoever, but there's kind of like, you have a problem with your hips or for the last, I don't know, year or two whatsoever, your surgeon is saying like, oh, well, you now need really a hip replacement. If that surgeon would tell you in there, like when you give the consent for this procedure, okay, so actually you are tested like to be anemic. We have two options now. Luckily, I have a slot for you tomorrow. So we can do the procedure tomorrow and then everything will be fine. And isn't that great? And he would say, yeah, that sounds good. But then he will say like, well, to tell you the full story, you're just tested to be anemic, which means you have a higher chance for an adverse outcome during your procedure. So what we could do, we could treat your anemia first and then schedule you in 3 or 4 weeks. And you will have a better outcome. I mean, we all would say like, well, of course, we want to do that, right? I mean, why would we take the risk if it's unnecessary? But unfortunately, we are not informed about that. I mean, this is like a knowledge we have gained over the last 1 or 2 decades. So that knowledge is not new, but it's kind of like still neglected and it's now growing. So there are like patient blood management programs all over the world who now understand the importance of that. So again, if you go into a procedure and the doctor will say like, oh, here your hemoglobin is a bit too low, we should give you a blood transfusion so we can just lift up your hemoglobin back to normal levels. And then we go into that procedure. And we as patients have no idea about it and say, well, if this is necessary, let's just do that. Now comes another couple of shocking numbers. I'm sorry to tell that to you, but this is data from actually only a very small part of patients, but very sick patients, those who need like a cardiac surgery. So when a patient needs a cardiac surgery, there is always a risk for a serious complication during the procedure or after the procedure. That means like a prolonged stay at the ICU, you're staying longer on a ventilator, you have infections, or you're dying. So the risk for these serious complications for cardiac procedures in an average human being is like 4%. It's a rather low number, but there's kind of a number. That's why nobody really wants cardiac procedures if not necessary. So if a patient goes into that procedure, the same patient, and being anemic, so this serious complication risk is going up to 12% already. If the patient is not anemic, but it gets a transfusion during the procedure, the risk goes up to 29%. And if the patient is anemic and gets a transfusion during that procedure, the risk for serious complication is 38%. That's not a number we want to accept, right? I mean, this is something where we would be happy just to do something to prevent that. Okay, so let's just talk a bit more about these blood transfusion. Why is a blood transfusion actually bad? I mean, we're all under the impression we save life with blood transfusions. There's all these advertisements, go and donate blood, we need that, which is true. Blood can definitely save a life. But blood transfusion is like a liquid organ transplantation. So you're getting the blood from another person into your system. And there are always some minor changes in these antigenes, in these proteins, which is around the blood cells, which makes the body thinking like, oh, there's an intruder in my system, so I need to fight that. And this is like on a smaller level, but if a patient is bleeding, if a patient gets a lot of blood during a procedure or while having a trauma, the body's immune response is weakened because it now has two things to do. It has the injury or the organ damage due to the procedure or the trauma, and now the organism is flooded with a foreign blood, and that makes it hard. I mean, of course, don't understand me wrong. If we have like a serious injury, if we have a serious accident, and we're bleeding like hell, we're going to the hospital and they give us blood, yes, that saves life. I'm not saying that every patient who's getting a transfusion will die a day later. Not at all. I'm just saying, like, if we look at the numbers and if we look at the outcome overall, then we know now a blood transfusion is something good when a patient really needs it, if the hemoglobin is totally down. But if we give a blood transfusion when it's not really necessary, it may be harmful. And the thing is actually, if we think about that, so blood, I mean, if we donate blood, which is really important that we have blood donors, but what happened with that blood? So that blood was like inside of your body before, everything is perfectly normal, it's physiologic, it's biology. But what we are doing with that blood, we put it in like bags, in plastic bags. Blood don't like that at all. It would be like dead, the cells would be dead in a very short time. There is no energy, no nutrition, no nothing. So what the people are doing, they're adding like additives to it, like something that can feed the cells inside and hopefully keep them alive. But blood does not stay fresh or good like the entire time. When you have like blood cells into these bags, they're kind of like losing their properties to squeeze through all these tiny vessels in our body. So the longer the blood is inside of one of these bags, the harder it is for a blood cell to go through all these small like capillaries. So again, a blood transfusion can be life-saving for sure, and we can be happy that we have like safe blood available. But what we know now, if we give blood which is not necessary, that may come with an additional like risk of like having adverse outcomes. So don't get me wrong, part of our patient blood management team is the chair of our blood bank. And he knows he's responsible for our blood, and he's like taking extra care of that all the blood that we have in our coolers is actually like tested for everything we have. But this is becoming more and more a question. We just talked about that here in the break. So we know now we have already kind of a shortage of blood sometimes. So depending on the time of the year and whatsoever, I mean, our society is getting older. So we're having more older, elderly people. And we're having, on the other hand, we're having better surgeries and procedures. But unfortunately, some of these like major procedures coming with a higher risk of blood transfusion. So that means the more people we have, the more elderly we have with cardiac procedures, orthopedic procedures, the more blood we need. And who are the donors of blood? These are the younger people. And the younger people, this population is going to shrink in the future. So some pessimistic people are already saying, like in the next maybe 2-3 decades, we may totally run out of blood. And that's why it is so wise and important to think about, is there anything I can do to prevent a blood transfusion, especially when we know there is a certain risk accompanied to that. What is interesting is when you look into like the publications, scientific publications, where experts given like, okay, this is what we have done in our hospital, so they're writing that down exactly. And if you look, and there's an expert group who just screened all these publications which were dealing with blood transfusions, and they have checked if the blood was given, the transfusion was given based on our current guidelines. And most of them, unfortunately, were giving out of the guidelines. So they have given some blood even though it was not really necessary. And this is why even in the physician world, most people are not really aware of this additional risk that comes with a blood transfusion. There are still people who are saying like, oh, there's nothing wrong about a good blood transfusion. And in fact, we know that especially again in elderly people, when they're kind of like, when they're recovering from a hip surgery and the hemoglobin is low, and then they feel like really like, oh, I'm so weak and tired. If you give a blood transfusion, oh, I'm feeling much better. So this is like the hard part to explain. So you will see the effect of these like upswing in hemoglobin immediately. But of course, you don't realize that there's an additional risk on it. So there's, in a certain way, people may feel a bit better as a short-term effect, but on the long run, it's not really like perfect. So again, I don't want to make you feel worrying about the next time being at the hospital whatsoever, and you see a blood transfusion saying, oh no, Dr. Haas was telling us I'm going to die when I get this transfusion. This is not what I'm saying, but I'm just saying like, we need to be really careful about the transfusion indication. So now coming to this patient blood management, because everything I've told you right now is not really new. So we know that really now for almost 2 decades or even longer. It was just more than 15 years ago that I think it was like a professor from Australia who was really into that, and he came up with the name of patient blood management. What does that mean? So patient blood management is a bit complicated definition. It's really a patient-centered, systematic approach to improve a patient's outcome and managing and preserving a patient's own blood while promoting patient safety and empowerment. So you see, this is like, there were a couple of smart people have sitting about this sentence like for weeks. But anyhow, I mean, in a nutshell, it's an interdisciplinary program to check what can we do that a patient is not bleeding as much or that we can avoid a blood transfusion. And there are actually a couple of things we can do. And part of that program, so we can just see if a patient is anemic before going into that procedure, and then we can just potentially treat this patient. So everything I'm saying here, we put that on our webpage, and you can just access it. And there's a bit more like the background information. Everything is written in a way that's hopefully easy to understand. But this is something which is important. We need to teach our patients about their own health, about their own blood. I think this is very important. So patient blood management is not just anemia. This is part of it. So we have to deal with the anemia management. But also when the patient is going into a procedure, and I will show that to you later. So there are a couple more things we can do to help to lower the bleeding during a procedure. And even after the procedure, when the patient is going to the unit, to the floor, or maybe to the ICU, there's still a couple more things we can do to make sure we're preserving a patient's own blood. And again, I will just show that a bit later. So that's why we're doing that. And this is like what we're working on right now. This is the Stop Anemia. It sounds very easy, but it's actually not that easy. So the only way to know if you're anemic is to test your blood. And that would be kind of like tough if we now send all the patients to their primary care physicians to a draw station at UF and just like test the blood, even if we don't know if anemia is present, yes or no. So let's just talk about the ways of anemia screening. So again, worldwide, the way this is working, you have to send a patient to a doctor, somebody's taking blood, and then we run a blood test. What we have started right now, and I mean, technology is improving, and there's now a handheld device. It's a bit like larger than a smartphone. That comes with this little clip on your finger, and it takes like 10 seconds, and it can measure here hemoglobin level. It's totally pain-free, it's a clip. So there's no harm to a patient. And it's really like, it's a very quick, you can just get the results. So now our idea is, and this is what we're working on, we want to screen all our patients when they're coming to see a surgeon for whatever reason. And the first thing that usually happens is you're going to one of these like vital sign stations and somebody's taking your blood pressure or is taking your heart rate or your body weight, whatsoever. What we want to do now, and we have actually started our pilot already, we screen every patient for anemia. It takes another 10 seconds, pain-free, patient is not charged for it. And after that, we have a number and we know if somebody is anemic, yes or no. We are using these, what the World Health Organization has published like decades ago. There's like a well-known threshold for anemia. And this is in terms of the hemoglobin level. You don't need to remember that number. So, but whenever like a female has like a hemoglobin level below 12, this is anemia. If a male person is below 13, this is anemia. So we don't do anything else than that. We just measure that number. And what happens next? We're going to hand over a little paper to our patients. We call that a snapshot. It sounds very cool. So in this patient, we give that to every patient, and on top of that here, we will write down the number from this individual hemoglobin level we have screened. And the patient is usually going back to the waiting area, wait a couple more minutes before the surgeon is coming. In that time, we hope that the patient may already read that little paper and saying like, oh, what is it about? Oh, there's anemia. What is anemia? Oh, that may have like a negative impact on my outcome. So actually, this is something interesting. Plus, we put a little QR code on the bottom right. So for all who have a smartphone, and in the meantime, I have the impression that pretty much everybody has a smartphone, we can check that already. So the patient should get some facts about it. We want to have like an informed patient about the blood health, about the status, if I'm anemic, yes or no. So what we want, and this is like actually starting now, that when you're going to see your doctor, you show them your card. Hey, actually, I was tested positive for anemia. What does that mean for me now? Or everything is fine, and then I have some additional information, and I can just like do whatever with that piece of paper. So the surgeon now has to make only one decision. The only decision is, does this patient now needs a surgery? Maybe in the next couple weeks or months? And does this surgeon is at higher risk for bleeding because of the procedure itself? So this is a procedure where like a hip surgery, cardiac surgery, where we know there's a fair chance of being transfused. So that's why the surgeon can say, we should check this. But the surgeon doesn't have time for this. So they're busy. They're in the OR. They're seeing like a zillion of patients per day. It would be kind of mean to tell them, hey, you have to do now all this on top of what you're doing on a daily basis. That's why the surgeon can send the patients who are tested positive for anemia. They can send them to our PBM hematology team. So what this team is doing, so this is just in a nutshell where we show the surgeon how easy that is. So we treat all your patients, so that means we're screening everybody, and the patient will get this snapshot. So once we tested this patient, you have to make just one decision if this patient may need surgery or is high risk for bleeding, and then just send it to PBM. So 1, 2, 3, done. That's what we want to show our surgeons, how easy that is. So what happens next? If you're truly anemic, and now comes the fun part, to treat anemia, iron deficiency anemia, that's the easiest thing on the world. You can just either swallow some tablets for a couple of weeks or month, and then your iron stores are filled. Or in severe cases, or if there's not enough time, you can get a one-time infusion of iron, and everything is done. And this is the difference, and this is what people have to understand. If somebody is anemic and you transfuse blood, so the blood cells, the numbers increasing in your body. So if you now test again, the patient is no longer anemic. But these like transfused blood cells, they're going to die. So that means after 2 weeks, you will be back in your previous status. And as your iron stores have been low before, they will be low after it. So you have not really treated a patient. You have just given something to bring up that number. If you want to treat iron deficiency anemia, you need this medication, and that's it. It is available worldwide, very easy. And again, the benefit, if you treat anemia, you have less infections, shorter hospital stay, less complication, lead plus transfusion, and a better outcome, a higher quality of your care. It's very compelling, I guess. Okay. So the way, let me just say here for one more second. So the way this is working now for the patient, just to explain how this is going. So that means when you saw your doctor and he was telling you, well, you showed me that your snapshot and I saw you're actually screened positive for anemia. And I think you need surgery in the next couple of weeks. We should send you to these PBM hematology specialists. So what's going to happen? They will create an order for you to go to one of our blood draw stations at Chance. This is where we're starting our program, and it's hopefully going to spread enterprise-wide. So that means once you're already at the medical plaza here, or you being somewhere at chance at one of our doctor's offices, you can just go straight to one of these draw stations. They're taking some blood to first confirm the anemia and also to figure out why you're anemic. Because as we saw before, iron deficiency is like the main cause of anemia, but there can be also other causes. And this can be checked with just one blood withdrawal. So, and after that, one of these PBM specialists will call you and saying like, hey, so we figured out you're truly anemic, and we figured out you truly have iron deficiency anemia. So we would love to schedule like an appointment with us. If there's not enough time to an infusion center, you get a one-time 30-minute iron infusion, and that's it. Or if there's enough time, we will prescribe some medication for you. And for those patients, I didn't tell you that part, for those patients who actually don't have a procedure, they were just there to see the doctor because they have some aching whatsoever, but no surgery is needed. But you're tested positive for anemia. So we don't want to let these people go without knowing. So what is happening in these post-visit summaries, so the written part we're going to send to your doctor, we will tell them, hey, this patient was screened positive for anemia. Please recheck and please make sure if this patient is really anemic and has iron deficiency, please treat this patient. So we don't want the patients to run away, even though they don't have surgery, knowing that they're anemic, but saying like, oh, nobody really took care of it. We want to inform you about it. And by doing so, we hope that we can just make our population a bit healthier. So at the point when we just screen enough patients, if we tell them you're anemic and we can just do something, or sometimes it's just easy as like improving your diary, so you're improving your food, whatsoever, having a look at it, you have all the components which are good, like iron suppliers, and then you can just hopefully treat yourself. Just two or three more things, and then I don't want to annoy you too much longer, and then we have time for discussion, which is always good. There's a couple more things we can actually do to help you to prevent bleeding or blood transfusion. So when you are going into a surgery, so first of all, we have, I think now, good tools available that can be some medications that we're going to give you during the procedure, which we know lower blood loss. Or we have some other medications which interacting with your coagulation system. The coagulation is a pretty complex interaction of proteins in your body, in your bloodstream, which making sure whenever you have like a vessel lesion, a little damage, an organ damage, they can help that there is a clot growing in the blood which stops the bleeding. And for this clot in your blood, we need some factors. And sometimes these factors are low, so we can measure that, and then we can just treat the patient. And by doing so, helping that the patient has less blood loss, and by doing so, has less blood transfusions. And by doing so, will improve the outcome. Shorter time at the hospital, less infections, and all the stuff I've shown you before. We have like a special test device available that goes way beyond my talk today. This is something when I can just like measure, analyze blood within a couple minutes and know already if there's kind of a derangement, if this patient needs something special, and then we can treat this patient right away with some medications. And that all helps to really lower the bleeding and the blood loss. We have something which we call a cell saver. It sounds very spooky. So this is a machine. When a patient is bleeding during a procedure, we can suction all the blood. That blood goes into like a reservoir, going into a special machine. It's going to wash it, filter it, and you can just capture all the red cells, harvest it, pump it into a retransfusion bag, and give it back to the patient. That's the own blood cells from a patient. And this has no complication like an autologous blood from a donor, from somebody else. It's your own blood. So it can be harvested, washed, and retransfused. This is not possible for some minor procedures where it's just like a bit of bleeding whatsoever, but you have kind of a major surgery that definitely helps to lower blood transfusions. So we have some really tools at hand that helps also for intraoperative to keep that better. So overall, All these efforts, all these steps of our patient blood management program, they help to what we now call blood health. Because this is so interesting. We all know, and I'm sure if we would walk around and just like ask you, you know everything about hypertension, that this is dangerous. You all know like parameters for like kidney things. So we know, and we know all about stroke and about MI, cardiac infarction, whatsoever. We're all little experts in medicine already. But so far, we don't know that much about blood health, which is so, interesting. The blood is the connecting tissue that flows freely to all of our organs, has an impact pretty much everywhere in our body, and as you've seen before, can have a huge impact if you need surgery. So again, just to sum that up, so the benefits of patient blood management is really, we have improved outcomes, it's improved the safety of our patient and a higher quality of care. And now comes the fun part. If you tell this to your administrators, to your C-suite people, to the high hierarchy people in your hospital, telling them, well, we have a new cool project here, so we want to do that now for all the patients, the first thing they will ask you, how much does that cost? Unfortunately, this is where we live, the world we live in, everything has to be paid, for sure, right? The good thing is about patient blood management, when you lower transfusions, so just to give you a number, we're transfusing every year a chance like roughly $10 million in blood products to our patients. If we know we can lower that by 20%, and this is what all projects have found like a reliable number, we can lower a couple $1 million per year. If the patients are staying like 2 days shorter than others, every day at the hospital, that's a huge amount of money. If we improve the outcome, you don't have infections, so we don't have to give you antibiotics. If you don't die, if you don't whatsoever, that all helps to reduce costs. So that means like with patient blood management, and this is like really proven by endless trials and analysis and whatsoever, we can reduce the number of blood transfusions by 40%, and it comes with a return on investment by 750%. So that means the hospital is making money with that. It's saving money. So a risk reduction, patient safety improvement, and lowering costs. Come on, there is no way to not doing it. But again, it needs this momentum. It needs the time to kickstart a program like this. At least weird guys like I am to really like making sure this is going to happen. It needs to be organized. There's a lot of work needed in the beginning. And that means this is part of my work time. Of course, I have to spend that for this program. So, and this also sums up in some costs for sure. But all these costs are easily covered by really the return on investment for the hospital. So that's why we think with patient blood management, everyone wins. And this is why I'm so happy telling this all to you. And we have started our pilot now, and we're including now in the next step, like our cardiothoracic patients. And then in the next step, hopefully all patients. And in another step, we want to do that enterprise-wide in each of the UF Health locations. So it's a big what we have like in front of us, but I think we are in a very good way. And I'm more than happy to discuss and taking any questions, and thanks for listening. Yes, please wait for the microphones so that we can all hear your questions.
Is an oximeter adequate to indicate anemia or not? Oximeter.
This little clip on your finger? Yes, you can just measure two things, the the oxygen content in your blood, so it's like a pulse oximetry, but on top it can measure like really the hemoglobin level. It's accurate, yes. We know that there's, with every of these like handheld devices, that's a very good question, there's always a minimal standard error. So it's not as accurate as a blood test. That's why once we screened a patient positive for anemia, the first thing we're doing in the lab is rechecking if the value was really that low. If it wasn't that low, then we don't like test the entire anemia panel. If it's low, and then we take in the second step, we test the anemia panel, making sure what was the cause or what is the cause of anemia. Good question, thank you.
Hi, thank you so much for teaching us about this. I have two questions. The first one's personal. I have an HFE-related hereditary hemochromatosis diagnosis, and I don't really know what that means, and I'm wondering if you could explain some of that.
Oh, I'm not an expert in hematology. I'm so sorry. It would be not fair giving you my half good answers to that.
Okay, I'll ask the other question.
Hemochromatosis, I mean, it's a nutshell, you have too much iron in your stores.
Right.
Yeah.
So the opposite of anemia.
Correct.
And the other question I had is, can you explain a bit about how the liver stores ferritin and how ferritin differs from hemoglobin and iron?
It's a good question. It's a pretty complicated way. So first of all, the iron is going with your food into your guts, and then there's a special transporter molecule in the vessel, in the wall of the colon and the intestines, transporting actively the iron into the body. And this transport can be regulated with another protein built in the liver. And so then we have like a storage protein in our blood, which is called ferritin, and the ferritin is taking the blood to the cells, to the liver cells, to the red cells, to the spleen, and there it's going to be stored. And the ferritin is the storage part. I'm sorry. So the transferrin is that one that like runs the iron through the blood, and the ferritin is the storage part in the cells. And this can be regulated so that once we are low on iron, the body can just like decrease another protein level to make sure this is going to be released and it's available for other cells at the moment. It's a rather complicated process. And so this is actually part of how we're testing it. So we can just test the concentration of these stores of the ferritin to check if a patient is anemic, yes or no. And we can also measure, so this transferrin, this like transport protein that runs through the blood, this can be saturated with the iron. So, and the more iron we're just taking on with food or whatsoever, so the more like acutely this transferrin is going up, because it's now transports all the iron, brings it to the stores, to the cells. And if this like the saturation is low, and that's another good marker that a patient is anemic. But then there are like a zillion other tests beyond that, which are going to help.
Thank you so much.
Yes, please.
Thank you, Dr. Haas, for giving us some very good information about this. I have a couple of questions. One, does the transfusion solve the problem forever, or is it the time limitation of? And the second one is, what causes the anemia?
Oh, good question. So first of all, I mean, a transfusion, as I said, it can like increase the number of red cells in your blood. So by doing so, when you measure hemoglobin, it will be higher. But the red blood cell, which is going to be transfused, has like a half-life of like 60 days whatsoever. And then it will be like taken out of your blood again. And then you will be back to your previous situation. So that means if the iron stores was low before, if you've been anemic before, a blood transfusion will increase the level, and then it will go down again, and you will be back in your anemic state. So that's why it's not a causative treatment. And to the second part of your question, good question. So what are the reasons for anemia? So as I said, the main reason is iron deficiency, which is usually like you don't give your body enough iron in your food. Or it can be like other things, like you're losing blood, like a bit of a time, like throughout your life. That can be heavy menstrual bleeding, it can be GI bleeds. This can be very like minor, so the patients sometimes don't even get this. That's why we're just also making these stool testing on blood. Because if you have like a chronic condition in your gut, and then this will like make your body will lose blood over time, tiny amounts, but that sums up. And so then the body is not like able to recover that quickly enough because the stores are low. Or pregnancy is like, we know that, this is a huge problem. If we check all pregnant women who are going to give birth, it's like 70 or 80% who are anemic. There's usually not a big thing with that, but now people have looked into that further. And to tell you, I mean, to read that all, when you compare like an anemic mom and looking into the outcome of the child as compared to a non-anemic mother, we know that this anemic mother's child will have like developmental delays. It can cause like autism spectrum disorders. It can cause a bunch of things we don't actually aware of. Those people who are studying this now, becoming more and more aware of how important it is really to treat anemia. And that's why now many gynecologists, like during pregnancy, checking blood levels. And when you see, oh, you're actually low on iron, again, it is so easy just to swallow these tablets for a couple of times.
Now, but the personal physicians nowadays do not have any, stool testing or anything like that that you do normally to see if there is any blood loss or anything like that. You just do it on your own? Is that what you?
It would be always that way. So first you need to check if you're anemic, yes or no. And that's the problem. So a doctor is never going to order a blood test if there's no good reason for it. So we don't do this mass testing. So like every patient is going to be tested. We're far away from that. So you have to come and see your doctor telling him like, oh, I actually have one of the symptoms. I'm feeling so weak and I'm tired all the time, or I have tingling in my fingers whatsoever. And then sometimes what happens, the doctors are checking your blood and seeing like, oh, you're anemic, and then they can treat it. But to tell you the truth, right now, what happens even in a hospital when we're just checking blood, we're so used to that most physicians are saying, oh yeah, that patient is a bit anemic. That's it. And it's like, so what are we going to do? Well, nothing, it's just anemic. And that's unfortunate. So we have to work on that people and physicians become more aware of that, and spending these extra minutes to say like, hey, why is that patient actually anemic and what can we do to improve that? Oh, yes, please.
I have a question.
Yeah.
An elective patient for major surgery was assessed that he will need a blood transfusion likely in the operating room. Is it possible that the patient who is selected for surgery can have his blood extract before the schedule so that he can use his own blood? And how many days would that be? I mean, if this is an acceptable practice, because you are talking about the danger of transfusion. Then the second question is, how do you differentiate? How do you define fresh blood from advanced blood? The difference and advantages.
So the problem is, if I got you right, so first of all, you can't give your own blood before the procedure because your blood is low on iron. So that would not improve anything. There have been like a technique where patients have donated their own blood. It was stored somewhere safe. So they went into that procedure and then have retransfused it. The problem with that, so first of all, it's a huge logistic advantage for everybody, making sure that the blood is really only going back to you. A requirement for that was actually that you're not anemic. If you're tested anemic, nobody would take your blood because they know it's useless. So this would be only working if you know you're going for, example, like a major hip procedure whatsoever. Then there was like a time we have done that. We have collected, you have donated your own blood, maybe like a week before whatsoever. It was stored safe, and then it was retransfused. The problem is, as with all blood products, whenever you're taking something out of the system, putting it in a plastic bag, it's not getting any better. And there's a small risk of infection whatsoever. So that means in the meantime, we have pretty much completely abandoned this. We are no longer doing this. And the thing is really even if you get blood from a relative whatsoever, so especially at COVID times, we heard that so many times that people were requesting, hey, in this strange world of COVID and diseases whatsoever, I don't want to get this blood from anybody who I don't know. I want to get this blood from my relative whatsoever. I feel much safer with that. Again, this was not a good outcome, because what's going to happen actually? Every donor, I don't know if any one of you has donated blood before. So the first thing that happens, you have to fill a questionnaire saying like, if there are any risk factors. So honestly, if you're giving blood to a relative, if you want to do him a favor and they're asking you, have you had any like, and then it's like, oh, no, I've never done that. So unfortunately, there was a tendency to give the right or appropriate answer, not just answering like really honestly. And again, every blood donation comes with a risk of infection whatsoever, so it doesn't make any sense. Please.
This is such a good segue. I was pre-COVID a long-time blood and apheresis donor.
Yeah.
I had no problems up until after COVID, and then every time I went, I would say, test my hemoglobin first, because their standards are much higher. When I go to my doctor and I got a blood test today,
Oh, wow.
he says you're normal.
Okay.
But according to like Life South, you have to have a certain amount, at least minimally 12.5.
Correct.
To be able to donate. So then what they do is they will say, let's try the other hand. And I always find that it's a different number. It's like it's the same blood, and I maybe you have some explanation as to how come a minute later on the other side of my body it's a different number.
No, I don't.
I've been trying to donate again, and they have to have their standards, and I understand that.
Yeah.
It's not anemia according to my doctor.
Yeah.
Any thoughts about that?
No, not really good ones. I don't want to hear that. No, it sounds interesting. So let's put it that way. I mean, the problem we are really running into, as we've talked before, we have like every other week we have like a slight shortage of blood, and we need that blood for like ensuring we have enough for doing all these fancy procedures we're actually doing at Chance. I mean, people coming from like a huge distance just to our hospital to get treated because of like whatsoever funny stuff we're doing. And we're having excellent surgeons here, that's for sure. But even those excellent surgeons sometimes need to transfuse because the surgery itself is so major. And so, this is becoming a problem in the future even more. So, for that reason, I think everything we can do to lower transfusion risk or the transfusion requirements in our hospital, that would be worth it. There was another question. Yes, please. And there's one more in the back, yeah.
And I will say, I recently, I've had the let's try a different finger experience before. But I recently did something with Lex South, and there's a huge shortage of blood. They're having to get blood from other states. Life South is because we don't have enough blood donors in our area. There's another company in the Gainesville area that will take your blood. It's not Life South, and it doesn't go to Gainesville hospitals. So I'm just going to give you 2 cents about that.
I run into that problem with the primary who says, "Oh, you're a bit anemic," glosses right over it.
Yeah.
Can I improve that myself through diet?
You probably, I mean, that's a really good question. So I think you probably can. Just to be, totally honest, I'm an anesthesiologist. I'm not a hematologist whatsoever. We have a hematology expert in our team. So that would be a good question for him, but I doubt he would have a good answer too. So first of all, I think, yes, with an appropriate diet with food intake, you can just help to offer enough iron to your blood. The problem is even with the iron tablets, if you have an iron tablet containing 60 milligrams of iron inside, it's just like a milligram or 2, which is going to be absorbed and going into your body. The process of the iron intake is very complicated, slow, and ineffective. So that means you have to do that really over a long time and just helping your body doing whatsoever to improve. This is part of the things we have nowadays in sometimes younger people having some fancy ideas about how they can improve their food diaries, their intake. So going to, I'm not judging or whatsoever. It's just they're if you eat healthy food, you will get enough iron. If you eat only very special things, there's probably not that much iron inside. That's the problem.
Actually, I think my question was just answered, was about how long does it take for, obviously it varies per individual, but after you start your iron supplements, about how fast does...
So for the oral iron, it takes weeks, really, at least, or months. For the IV iron, so we know that after 2 weeks minimal, 3 weeks, you have like a sufficient increase in your numbers. So that's why the iron infusion is unfortunately so much better, even though we would love to avoid that because it's another like needle stick and you have to lay there for 20, 30 minutes, even though this is not the worst. If you have like the alternative of not like being treated or getting this one-time iron infusion, I would always say, yay, hooray, is this something we can do?
And what is the second most common cause of anemia that you went into?
It's pregnancy. Yeah. That's not true for both of us, right? I mean,
I guess I have one more question.
Is there any connection with heredity and anemia?
Not that I know of. I mean, there's like, I think there is some chronic infection which can be inherited. So there may be a cause, a way of why you're getting anemic more easily, but typically not. This is like, not that I know of, nope. Good question. We have a really good audience here, like very into that. So I love it. I love it. That's fantastic.
Thank you so much for speaking today. I really appreciate it.
I would thank you for listening.